interphalangeal joint will cause, as you can see in the X-ray, ulnar deviation, and you can see in the the joint affected in the metacarpophalangeal joint. The, that the Because of that, the fingers are deviating towards the ulna, and you can see a volar deviation. I don't think you can see it because it's a 2D figure, but there's volar or palmar deviation at the proximal interphalangeal joint. Um, Moving on, there are furthermore disabilities you can see. This is called the swan neck deformity, where there's flexion at the distal interphalangeal joint and hyperextension at the proximal interphalangeal joint. As you can see in the image, there's flexion, the distant, and here there is hyperextension of the proximal interphalangeal joint. And there's the Boutonniere's deformity, where there's flexion of the proximal interphalangeal joint and hyperextension of the distal interphalangeal joint. Hyperextension, flexion, flexion, and hyperextension. Okay. These are the usual presenting symptoms you can see. Also, you can see some trigger fingers. Trigger fingers, you can imagine it, fingers on a trigger. And more common symptoms are flexor tendon tenosynovitis. So pretty frequent. Okay. Now, these are the symptoms you'll see in a clinic usually. Now, we'll move on to the constitutional symptoms, which are weight loss, fever, malaise, and cachexia in very severe cases. Uh, in much, there are extra-articular manifestations of the disease. Most common form is subcutaneous nodules. Uh, the nodules are sometimes adherent to the tendons, uh, the bursae, and even the bones. They're not just skin nodules. And when it comes to the nodules on the tendons, it usually forms in the tendons that are subjected to the most amount of friction. For example, the Achilles tendon. Um, Surprisingly, the nodules also occur in the lungs, pleura, and the pericardium and the peritoneum. It's so weird that it occurs there. I just thought it was a skin manifestation. Anyway, then moving on to pulmonary manifestation, it causes pleuritis. Most common causes pleuritis, which is presented as chest pain and dyspnea. And pleuritis causes pleural friction, or also known as pleural rub, which might progressively lead to an effusion. Okay, and another manifestation of pulmonary RA is uh, interstitial lung disease, interstitial pneumonia, and NSIP, which is non-specific interstitial pneumonia. Now, usual interstitial pneumonia presents in an X-ray with a honeycomb-like structure, and it involves the edges of the lung and the bottom of the lung. Whereas the non-specific interstitial pneumonia presents with ground glass opacities, and it leads to traction bronchiectasis. What is traction bronchiectasis? Is due to a lot of damage to the interstitium of the lung, there is fibrosis. Due to fibrosis, the fibroblasts contract, leading to retraction of the bronchioles. Uh, if I draw it like this, it causes pressure in this direction. It causes it to the lumen to obliterate completely due to this pressure of constriction from all the fibroblasts. If this is the bronchiole and there are fibroblasts all around it, they are contracting and they're pulling the bronchiole in all directions, and that causes obliteration of the bronchiole. Interstitial lung disease usually means that the patient has poor prognosis. You can see that by measuring the total lung capacity. And if you treat them with immunosuppressants and steroids, you might see an increase in total lung capacity. So that is your prognosis indicator, TLC. Now, one of the major lung diseases is idiopathic fibrosis disease. And how do we differentiate this idiopathic fibrosis disease uh, from the lung disease that you see in RA? Is you actually give immunosuppressants. When you give immunosuppressants, you'll see an increase in total lung capacity, which means that the origin of this lung disease is autoimmune in nature. So That's how you distinguish it from idiopathic fibrosis disease. As we already saw that nodules are also formed in the lungs. So these are called the pulmonary nodules. Not to be confused with Kaplan syndrome, where nodules are formed secondary to silica exposure. So that is the other DD for pulmonary nodules. Other pulmonary manifestations are bronchitis and bronchiolitis, pretty basic. Now, moving on to cardiac manifestation, it leads to pericarditis, which is clinically silent and it's scary because it presents in less than 10% of clinical patients. But after autopsy, you'll see that there is carditis in greater than 50% of the RA patients. So, if the patient has pericarditis, it's clinically silent. So, make sure you check for that, do a echo, and see, look for any pericardial effusions and stuff. Okay. Next, cardiac manifestation is cardiomyopathy. Cardiomyopathy is presence as it presents in two forms: restrictive and dilated. Restrictive because of damage to the myocardium due to infarcts leading to fibrosis. This causes restrictive cardiomyopathy, and it also causes dilated cardiomyopathy due to antibodies against the myocardium itself, which leads to myocarditis. So myocarditis causes dilated cardiomyopathy, and fibrosis causes restrictive cardiomyopathy. The most one very high yield point is mitral regurgitation. Uh, very common MCQ. It's the most common valvular disease that you see in RA. Later, we'll come to know that RA is the death due to RA is due to cardiac disease, which is pretty surprising. Okay, moving on to the next system. It's the vascular system. RA presents obviously as vasculitis. Vasculitis, how do you diagnose? You'll see cutaneous signs, which are petechiae, purpurae, digital infarcts, uh, digital infarcts, and lower extremity ulcers, gangrene, and livedo reticularis. Okay, so livedo reticularis is a pretty cool sign. If you see in the lower extremities, it looks like a zombie leg. It's just that there's a leg and the blood vessels are in a state of high pressure due to blockages in multiple parts. So they're pretty engorged all over and they're forming a reticular pattern over the lower extremities. So red blood vessels engorging through the skin in the legs. So it looks pretty scary. Sometimes wish I had it. It looks pretty cool. Okay, vasculitis is also associated with polyneuropathies. Also, polyneuropathies, you feel maybe pain or other stock and glove manifestation of neuritis. Just like it's seen in diabetes, it's not that. It's just very diffuse because vasculitis doesn't have a specific location. Um, other moving on to the next manifestation is the hematologic manifestation, very high yield point. RA causes normocytic normochromic anemia. Uh, Another important point to know that there is an increase in platelet count. That is because of the high amount of mediators in our blood, which causes an acute phase reaction and leads to an increased production of platelets. There is a hematologic manifestation called the Felty syndrome. It's a triad of three things, uh, composed of nodular RA, splenomegaly, and neutropenia, very high yield point. Felty syndrome causes splenomegaly, which is the cause of this normocytic normochromic anemia. Okay, moving on to the next system. RA causes lymphoma, that is diffuse large cell B cell lymphoma, very common MCQ being asked. Okay, um, so let's look at some fun facts. I find these super fun. Most common cause of death in RA is cardiovascular disease, like I already told, which is weird because I didn't think people would die of RA. I just thought they'll live in pain and suffer, and that excites me somehow. Okay, hypogonadism. Sorry, RA causes hypogonadism. and osteoporosis. I don't know if the cause of knows if the cause is due directly related to RA or is it due to the corticosteroid treatment. So now moving on to the epidemiology of RA, it is most common in females. The ratio is almost 2 to 4:1, female to male. Okay. Now moving on to genetics, it's pretty interesting. So genetics of the disease stems from an abnormality in MHC class 2 molecule. MHC, because of this abnormality, MHC recognizes self-antigens, which leads to autoantibody production. So the autoantibodies you see are anti-CCP and cyclic cetylated polypeptide antibody and RA factor, which is an anti-IgM. It's usually an IgM antibody against the Fc portion of IgG. Okay. Okay. So one very important point that you need to know is the shared epitope, which I've denoted as SE over here. And I'm going to keep calling it as SE throughout, so make sure you know that. So alleles of HLA DR beta 1 gene. Okay. So I'll try to expand this for you. What is okay, in our body in chromosome? Let me just show this to you. Okay. In our body in chromosome 6, there is the HLA. This it contains the MHC complex, and the MHC complex contains the HLA genes and the non-HLA genes. Okay. Now the HLA genes for MHC complex 1 are located in 6p21. Similarly, somewhere in chromosome 6, MHC complex 2 is located. Now, in if to expand HLE DRB1, so HLA D, HLA is the gene, D is the locus, DR is the locus, beta is the subtype, and 1 is the allotype. There's just different types of the same gene, different transcription products of the same gene that are responsible for causation of the disease. Anyway, let's imagine the protein molecule produced by HLA-DRB1 gene. In that protein molecule, in a position 774, I am assuming it's the carbon molecule position, but I'm not really sure. So between 70 and 74, there's a bunch of sequences called the shared epitope. So obviously of this genes, there are two alleles, and the two alleles share a common epitope at position 70 to 74. That epitope is called the shared epitope. And there is a defect in that shared epitope region, is which narrows the source of the disease down for us. So shared epitope is a pretty important concept to know. So carriership of SE from one generation of to another resulted in an experiment with people producing anti-CCP antibodies. So you can't draw a direct relationship, but you can say that position of SE uh, may cause you to produce anti-CCP antibodies, but not always. It's not a direct conclusion. Okay. Anyway, the most disease is produced by the genotype of HLA-DR beta 0401. 04 is the subtype, 01 is the allotype. Okay. 0101 and 0404 also produce the disease. Non-HLA alleles are responsible for 5% of the risk. Some non-HLA alleles are PTPN22, protein tyrosine phosphatase non-receptor 22. It There's a gain of function mutation in this gene, leading to abnormal thymic selection of T cells. So that's what I've written here. If you can't understand my handwriting, it's abnormal thymic selection. Okay. Another non-HLA gene is PAD14, peptidyl arginine deaminase, which converts many arginine residues on peptidyl chains on various proteins in the body and adds citrulline, replaces arginine and converts it to citrulline. Now, this citrulline is detected by our anti-CCP antibodies. Okay, now those were the genetic factors. And now coming to environmental factors. Smoking. Smoking, tobacco smoke causes an increased citrullination of most peptides in our body. So that's pretty interesting to know. Streptococcus, P. gingivalis, EBV, all are supposed to be associated with RA. P. gingivalis antibodies against P. gingivalis lead to are apparently antibodies also against the joints, which causes inflammation of the joints. Okay, now moving on to the pathology of this chapter, finally interesting part. RA affects the synovial tissue and the underlying cartilage and bone. So synovial tissue, cartilage, and bone. It's high to know that those three things specifically. Okay. Now here is a diagram of our typical synovial joint. Here is the hyaline cartilage, and here is the fibrous cartilage. And in the dotted line, I have labeled the synovial membrane. Now, let's magnify that synovial membrane. The synovial membrane is divided into an intima and a subintima. The intima faces towards the inside of, towards the outside of the joint cavity, and the subintima faces towards the inside. And this is the blood vessel inside the synovial membrane. So the plasma oozes out of the blood membrane, the blood vessel, and in the intima there are two types of synoviocytes. Synoviocyte type A and type B. Type A is a macrophage, and type B is a fibroblast. And this fibroblast secretes a bunch of stuff. It secretes collagen, fibronectin, and laminin to form the matrix of the synovial fluid. So after all this, the plasma oozing out of the blood vessel and the synoviocytes secreting that stuff, it forms some good shit. That good shit is called synovial fluid, and it contains two major constituents. That is hyaluronan and lubricin. And it's very high to know these 2 points. Okay, now continuing to the pathology. Now, inflammation causes thinning of the fibrocartilaginous layer and synovial hyperplasia. These are what you will observe in microscopy. Thinning of fibrocartilage and synovial hyperplasia. And most commonly, you will see a pannus formation. Pannus is a production of or a growth of fibrovascular layer that can invade the cartilage or the underlying bone. So it can cause bone and cartilage lesions. And at the site where it invades the bone, it causes osteopenia, that is reduction in bone substance. Okay, we'll see how that happens later in the pathogenesis. Okay, now T cells comprise about 30 to 50% of the infiltrate, of the inflammatory infiltrate inside the synovial joint. And literally all WPCs are present. Uh, Sometimes in severe cases, follicles may be formed in the matrix. Now, damage to the bone is carried out by the osteoclast. However, we know that we found cells that exhibited CD68, which is a characteristic marker of osteoclast. And they're surprisingly they're found at the pannus bone interface. So where the pannus is growing, there osteopenia is happening due to this osteoclast formation. Okay, now let's talk about the bone lesions that occur if you see microscopically. Bone lesions at MCP, the metacarpophalangeal joint, always occur on the radial side. Why? Because all the tendons and all the synovial sacs insert on the radial aspect of all MCP joints. And since the synovial sacs contain inflammation, that is where the pannus formation occurs on the radial side. And that is where you'll see bone lesions. So the pannus bone interface. So this point just highlights the application of the pannus bone interface. Okay, now next you'll see periarticular osteopenia, uh, which is loss of bone substance around the joint, which is obvious. Oh, one more weird feature you'll also see is there is inflammatory substance found also in the bone marrow. So the cortical bone has gotten so thin that the inflammatory cells are just diffusing across the cortex into the bone marrow, and they're found usually at the metaphysis. Uh, Osteopenia, if you look at it microscopically, you can see thinning of the trabeculae. It also causes other bone lesions found are osteoporosis, and there's also destruction of the articular cartilage, as you already saw. This is the fibrous cartilage. Okay, now moving on to the cool part, that is pathogenesis. Uh, Pathogenesis is based on the following premise. Anti-CCP antibodies are directed against the deaminated peptides produced by the dysfunctional PAD14 enzyme that we already saw, produced by that non-HLA gene. These antibodies recognize the citrullinated regions of most matrix proteins and cause agglutination and destroy the matrix protein and cause a release of so many inflammatory mediators that causes inflammation. Now, smokers show increased citrulination, and so do people who are exposed to silicon. P. gingivalis causes autoantibody production against the synovial fibroblasts. Synovial fibroblasts contain TLR, and TLR234 recognize the lipopolysaccharide of P. gingivalis, and it releases so many inflammatory mediators that will amplify the rheumatoid arthritis inflammation. But it's important to know that it is not the cause of RA. It just acts as an adding factor. Okay. So the main cause of RA is auto T cells due to antigenic stimulation. So there's a nice phrase that comes here. It's called guilt by association, which means that there is no direct T cell abnormality, but there is some self antigen being presented to the T cell, which leads to the production of self antibodies. But there is no improper thymic selection. So it probably means that the antigen contains a replicating a self antigen domain and a domain that the T cell recognizes as foreign. So it might contain two domains, a foreign domain and a self domain. But the part of the antigen that's binding to the T cell is the foreign domain, but the antibody that's being produced is probably against the self domain. So that is how the disease is hypothesized to be produced. Okay, now we'll go into the basic process of T cell activation. So an antigen presenting cell will present the antigen, self antigen to the T cell. The T cell, along with CD28, the CD80 B7 molecule on the APC will co-stimulate CD28, and the MHC2 will stimulate the T cell receptor. T cell will differentiate into TH1 and TH17. TH1 cells will produce IFN gamma and TNF alpha, and TH17 will produce IL-17, TNF alpha, and GM-CSF. Okay, now IL-17 is a cytokine responsible for autoimmunity. They don't know how, but it is seen in a lot of autoimmune disorders. TH1 cells will cause cell-mediated immunities. And how will that happen? TH1 cells will, with the help of CD40 ligand, stimulate B cell with CD40 on the CD40 receptor, and B cell will produce Rh antibodies and anti-CCP antibodies. TH1 helper cells, with the help of IFN gamma, will call macrophages to the site of inflammation, and there'll be a tremendous amount of cytokine release, which causes an enormous amount of inflammation. So macrophages are said to progress the disease of rheumatoid arthritis. Uh, T cell starts the disease, and macrophage progresses the disease. Now, TH1 cells and macrophages release the cytokine tumor necrosis factor alpha. Now, tumor necrosis factor alpha is pretty notorious and it does the following things. Uh, it increases the cell adhesion molecules in the synovial sites or in the membrane of synovial membrane, which causes more inflammatory cells to come to the synovial joint. There's increased pain sensitivity, which is probably why the patients are in tremendous amount of pain. Uh, TNF alpha causes the fibroblasts to produce increased amount of matrix metalloproteinases, which causes the destruction of articular cartilage. TNF alpha also increases the expression of rank L ligand, which is a stimulator of nuclear factor kappa beta pathway. Okay, we'll explain. We'll see that right now. So the T cells and monocytes, sorry, just the T cells and many other inflammatory cells like the macrophages, they contain the rank ligand, which stimulates the rank receptor on the osteoclast. Stimulation of this receptor causes activation of osteoclast and bone erosion. There's one thing I didn't know, that monocytes can also be converted into osteoclasts, and that is from stimulation of MCSF secreted by our Th17 cell, as we already saw, and and the macrophages also, and stimulation of rank by rankel from T cells, and it will differentiate into a pro-osteoclast that will later differentiate into an osteoclast and cause bone erosion. So monocytes can also differentiate into osteoclasts. That's very high yield to know. I never knew that. Now there is another uh, molecule that is produced due to TNF alpha, which is DIC KOPF1, or also expressed as DKK. DKK inhibits the WNT pathway. The WNT pathway normally causes cell growth, but since DKK is inhibiting the WNT pathway, there is decreased bone growth. So there's increased bone destruction and decreased bone growth, and hence there's osteoporosis, osteopenia, and all those bone lesions we already saw. Okay. WNT pathway also normally increased OPG, which is osteoprogesterone. Osteoprogesterone acts as a decoy receptor to rank for as a decoy receptor for rank L ligand. So all the things that produce rank L will come and bind to OPG, and the OPG will basically cause competitive inhibition of the rank ligand present on the osteoclast, and hence decrease the activity of the osteoclast. So TNF all alpha increases the production of DKK, which decreases the WNT pathway. Hence, OPG expression is also decreased. So there's tremendous amount of bone destruction and decreased bone formation. Now, how do you diagnose RA? You've observed all these clinical symptoms and you've come down, you've narrowed down your differential to RA, and you want to make sure because you don't want to get sued. So there is an ACR criteria, and the objective is if you want to diagnose a patient with RA, he has to have a score of greater than 6. So it's divided into three things: joint involvement, serology, acute phase reactants, and duration of symptoms. The patient must have at least one joint involvement, and one of the so if you have one large joint involvement, then it's probably osteoarthritis due to trauma or many other causes. 2 to 10 large joints, 1 point. 1 to 3 small joints, 2 points. 4 to 10 small joints, 3 points. And greater than 10 joints with at least one small joint involvement, the score is 5. Serology, negative RF, negative ACP is 0. Low positive RF, which is less than 3 times uh, normal. You give less than 3 times the upper limit, you give 2 points, and greater than 3 times the upper limit, you give 3 points. Acute phase reactants, you check for CRP and ESR. If it's abnormal, give 1 point. If duration of symptoms is less than 6 weeks, it's probably acute arthritis or any acute condition. If it lasts for greater than 6 weeks, then it's 1 point. Now, what are the lab investigations you're going to do? Obviously, ASR and CRP. CRP are going to check just like we already saw in serology. Sorry, in acute phase reactants. And you're also going to do serology for anti-CCP and RF factor. One thing to know about these serological indicator is that anti-CCP is the most specific. It's not the RF RA factor. It's the anti-CCP antibody, which is 95% specific. RA factor is seen in 75% to 80% in the form of IgM. That, but the thing about RA factor is it's present in Sjogren syndrome, in SLE, and many other autoimmune diseases, even in diabetes, mellitus sometimes. Okay. Uh, After you're done with the blood examination, you go for if that's inconclusive, that's not enough, you'll go for synovial fluid analysis. Synovial fluid analysis, you'll see if he has, if the patient has RA, he'll have 5,000 to 50,000 RBC, WBC cells, not he, she, because it's more common in females. Whereas the normal limit is just 300, 200, 2,000 cells, WBCs per microliter. You can also look at a very cheap investigation, which is the X-ray. Here in the X-ray, you can see there is decrease in the joint space progressively. You can see that progressively there's decrease in joint space. There's more here, and there is periarticular osteopenia in these areas. Progressively, there's decreased amount of bone, which signifies that joint involvement. Most sensitive diagnostic test will be your MRI, which for synovitis you'll see an amount of increased joint space initially, and you'll see a lot of, you probably see cloudy synovial fluid. I don't know what an MRI looks like. I have no clue. Anyway, you'll also do ultrasound. What you can see in ultrasound is increased joint vascularity due to all the pro-angiogenic factors released during inflammation. Okay, now we'll look at the clinical course. Clinical course is variable, depends from person to person. There is a stage of symptoms, and there's a stage of remission, sometimes lasting for 3 to 6 months. Now, how will you treat this disease? Disease will be treated with first-line drug, obviously NSAIDs, diclofenac injections, ketorolac injections. You can start with ibuprofen. Okay, NSAIDs obviously won't work. They suck, and they cause GI symptoms, GI ulcers, and particularly not recommended in old age people due to these side effects. Now, when NSAIDs don't work, your second line will be glucocorticoids. Glucocorticoids, you'll give oral prednisone, low dose therapy. If there is way too much pain in a specific joint, you'll give an intra-articular triamcinolone injection. The thing about glucocorticoids is, you guys know the side effects. It causes osteoporosis and many hormonal dysfunctionalities. So for our osteoporosis, you can prescribe bisphosphonates. Now, because of the high side effect profile of glucocorticoids, you might move to a drug class called disease-modifying anti-rheumatoid drugs. Now, these drugs can be classified into TNF alpha and non-TNF alpha inhibitors. So non-TNF alpha inhibitors, the drugs are hydroxychloroquine, sulfasalazine, methotrexate, and leflunomide. Thing to know about this is methotrexate is the most common drug used, although it's excreted only by the kidney, so you have to you have to adjust your dosages accordingly in old patients who have kidney failure. Leflunomide is a pyrimidine synthesis inhibitor, so it should be avoided in pregnancy. So should methotrexate. Hydroxychloroquine causes severe toxicities like retinal damage and cardiotoxicities, etc. Now, coming to the TNF alpha inhibitors, as we saw, TNF alpha was a very notorious cytokine. It did various stuff. So maybe TNF alpha inhibitors could be a good choice. So examples of such inhibitors are infliximab, etanercept, adalimumab, golimumab, setrolizumab, etc. There are more non-TNF, there are more biological agents. For example, abatacept, which is a combination of extracellular domain of CTLA4 and IgG antibody that prevents the co-stimulation reaction that we saw, the APC T cell co-stimulation reaction, CD28 and CD80/86. It prevents that co-stimulation reaction. That is the function of abatacept. There's anakira, which is a natural IL-1 receptor antagonist. Rituximab, which is an antibody against CD20. CD20 is a receptor seen on B cells. So if you have an antibody directed against CD20, then it will lead to increased B cell destruction in the hope of reducing the inflammation at that site to decrease antibody production. Okay, and then there is tocilizumab. Tocilizumab is the antibody against IL-6. IL-6 is one of the mediators of the inflammatory reaction. Uh, and then there is another class of drug which is called the small molecule inhibitor of small molecule inhibitors, and the example is tofacitinib. Tofacitinib inhibits the Janus kinase pathway, and Janus kinase pathway is an essential pathway seen in T cell receptors for their changeover to Th1 and Th17 subcategories. So if you go and inhibit that, T cell won't differentiate, and there'll be reduced inflammatory reaction. So it inhibits Janus kinase 1 and 3 pathways. It's very high yield to low, this last drug, tofacitinib. Okay, now
An
moving
alternate
on to objective.
classification could be done, yeah. Like you could have an
Huh?
alternative classification where you look at the drugs in DMAIDs in terms of being synthetics and biologicals rather than TNF alpha inhibitors and non TNF alpha. That would be like
Yeah, sure.
a more specific classification. That way you can, separate the older drugs from the newer drugs. So you put all your methotrexate, hydroxychloroquine, and all of those into one class, and then you
Ah,
have your biologics later because those are the
quite
ones
cool,
that
cool.
are used more recently. Just an
Yeah,
alternate
yeah,
one.
cool, cool. I'll see that. To read format, man. Okay. Anyway, the coming to the last part is the objectives of therapy. So our objectives are to start early aggressive therapy, uh, constantly modify your therapy according to the symptoms of the patient, and individualize the therapy because the patient can present to us with an array of symptoms, as we already saw. We discussed so many symptoms, and you can the final objective is just to achieve remission as soon as possible because it's really painful for the patient. So the strategy they follow is treat to target approach. So just treat the symptom. No difference between early and established RA. Just don't follow the protocol. Start with NSAID, then go to glucocorticoid. Just no need to follow that protocol. Just treat any early patient as though they have already had RA for a long time, because we want to achieve early remission. So treatment starts off with methotrexate, and quickly within 3 to 6 months, you see if there is remission. How to check if there's remission? There are remission criteria. So there's tender joint count should be less than one, less than or equal to one, swollen joint count less than or equal to one, C-reactive protein less than or equal to 1 mg per deciliter, and patient global assessment scale, which I don't know what it is. I have to figure that out. I don't know how to quantify this, but I'll tell you guys. I'll send you a picture later. Anyway, or at any time point, patient must have simplified disease activity index score of less than 3 points. Okay. Now, after 3 to 6 months of methotrexate therapy, you'll see if there's remission. If there's a remission, good, well and good, continue with methotrexate. If there's no remission, add DMARD. Start off with an anti-TNF alpha inhibitor. If it doesn't work, switch to a different class. Don't switch to another TNF alpha inhibitor because another class might just work better. Usually, small molecule inhibitor like tofacitinib can be used because it's a very new drug, very nice drug. Switch to a different class. Don't stick to the same class. In early RA, it is found that oral triple drug therapy has been successful. Oral triple drug therapy consists of hydroxychloroquine, leflunomide, and methotrexate. If medical therapy is not sufficient, joint arthroplasty and silicone implants surgically can be placed. And as I already said, in old age, look for always assess serum creatinine because all the DMARDs that you're giving, methotrexate, they're all excreted usually by the kidneys, and you have to see if you have to look for kidney damage, and especially in old age since their kidneys might fail. So always keep an eye on serum creatinine. Yeah, so that's it for RA today. Anybody, anything to add?
Harrison, no?
Mm, yeah, bro.
Mm,
It's
no
pretty
wonder.
well laid out. Good book, but it just takes time. It took me time because I had to like make notes again because I never made notes in
Mm-hmm.
the first place. But
Yeah,
yes. Mm,
it was nice, bro.
thanks, bro. Okay, bye, guys.
See you, Bob.